Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in cardiology, that is the hypertension. So, first of all, you need to know what are the types of the hypertension. So, we have two important forms of hypertension, that is primary, or it is also called essential hypertension. Right, primary, or it is also called essential hypertension, and the other form of hypertension is secondary hypertension. Right, so these are the two forms of the hypertension, primary and as well as the secondary hypertension. So in case of primary or essential hypertension, it is idiopathic. Right, we don't know what exactly is the cause for the hypertension. Whereas the secondary hypertension is that where you have a presence of an underlying etiology for the development of hypertension. That is what is called as the secondary hypertension. Now, if you take so if you see this question, most common cause of hypertension in adults is the essential hypertension, pheochromocytoma, renal artery stenosis, chronic glomerulonephritis. So the most common cause of hypertension in adults, please remember, it is the essential hypertension, or it is also called primary hypertension. So this primary or essential hypertension, it accounts for 85% of cases. Right, it accounts for 85% of the cases, and it is not possible to define a specific underlying cause. Okay, so the etiology is idiopathic. Right, the etiology is idiopathic. We don't know what exactly is the cause, and almost like 70% of them, they have a positive family history. Right, 70% of them, they have a positive family history. Right, so that is what is your primary or the essential hypertension. Then if you take the secondary hypertension, so secondary hypertension, it accounts for 15% of cases. Right, it accounts for 15% of cases, and this secondary hypertension, it is a consequence of a specific disease. Right, so this is a consequence of a specific disease. So that is what is the secondary hypertension. So you have an underlying etiology for the development of secondary hypertension. Now let me discuss what are the various causes of secondary hypertension. So secondary hypertension, we have discussed, it is a consequence of a specific disease. Now let me tell you what are all the various etiologies which will cause the secondary hypertension. So if you see this question here, a 44-year-old woman presents with episodes of headache associated with anxiety, sweating and a rapid pulse rate. At the time of her initial consultation, her blood pressure was 150 by 95 millimeters of mercury, but 24-hour ambulatory monitoring shows a peak of 215 by 130 millimeters of mercury associated with symptoms described above. Which of the following would be your initial diagnostic procedure? So what are all the various symptoms which are seen in this clinical scenario? One is the headache, anxiety, sweating and rapid pulse rate. And if you see the blood pressure of the individual, right, the peak, it is around 215 by 130 millimeters of mercury. Now where is that you will have this clinical scenario? You can come across this clinical scenario in patients with pheochromocytoma. Right, so in patients with the pheochromocytoma, you will have this clinical scenario. So how will you diagnose the pheochromocytoma? MRI scans of the abdomen and as well as the pelvis. See, this will be useful in making out how is the adrenal gland, but that will not be the first investigation. That will not be the initial investigation. The question asked is initial investigation. MRI scan will definitely show if there is any adrenal tumor, like it will be useful for diagnosing your Cushing's, it will be useful for diagnosing the adrenal tumors causing Cushing's, or it will be useful for diagnosing the Conn syndrome, right, which is also the tumor which is originating from the adrenal cortex, and it is also useful for diagnosing the pheochromocytoma as well, but that will not be the initial investigation. Measurement of random plasma catecholamines. Please remember, catecholamines should never be measured in a randomly. Why? Because this catecholamines, there is a pulsatile secretion of the catecholamines. So, whenever there is pulsatile secretion, that pulsatile means what? Intermittently there will be release of the catecholamines. So, whenever there is pulsatile secretion of the catecholamines, please remember, random plasma catecholamines should never be measured. So, what you have to do? You have to measure the 24-hour urinary catecholamine levels or 24-hour urinary catecholamine metabolites. That includes measurement of urinary metanephrines over several 24 hours period. So, the best answer or the initial diagnostic procedure what you need to do is measurement of urinary metanephrines over several 24 hours period. Then glucose tolerance test, this is mainly for diagnosing diabetes mellitus. Pharmacological provocation using clonidine, right, this is an incorrect statement. So, the correct answer here is measurement of urinary metanephrines over several 24 hours period. So, this will be the correct answer for diagnosing the pheochromocytoma, which is one of the secondary cause for hypertension. Now, after having discussed about one of the etiology which will cause secondary hypertension, let me discuss some other causes as well. So, if you see a question here, most common cause of secondary hypertension is renovascular disease, pheochromocytoma, renal parenchymal disease, hyperthyroidism. Let me tell you all these, right, all these etiologies, all these options whichever are given to you here will cause secondary hypertension. But among these, which is the most common cause for secondary hypertension? It is the renal parenchymal disease, which will be the most common cause for the secondary hypertension. Then followed by that, you need to know what are the renal causes, endocrine causes individually. So now let me discuss what are the renal causes for the development of secondary hypertension. Renal causes include number 1, chronic renal failure. Next, glomerulonephritis. Followed by that, the next important cause is chronic pyelonephritis. Right, chronic pyelonephritis. Then followed by that, collagen vascular disease. Next, followed by that, polycystic kidney disease. Next, in the last, we have renal artery stenosis. Right. So, these are the renal causes for the hypertension, right? And out of these also, one of the most important cause will be your glomerulonephritis causing the secondary hypertension. Then you need to know what are the endocrine causes for secondary hypertension. Endocrine causes for secondary hypertension include number 1, pheochromocytoma. So, pheochromocytoma, it is a tumor from the adrenal medulla where there is excessive release of catecholamines. Then Cushing's syndrome. So Cushing syndrome, if you see, it is the disorder of the adrenal cortex where there is excessive release of the steroids which will make the individual to land up in hypertension. Then we have the Conn syndrome. Conn syndrome is also the disorder from the adrenal cortex where there is excessive production of the aldosterone, and that will make the individual to develop hypertension. Then followed by that, hyperthyroidism. So hyperthyroidism, these individuals, they will mainly have the systolic hypertension. Then hypothyroidism, where the individual has the presence of diastolic hypertension. Next, acromegaly. Acromegaly is a clinical condition which is characterized by excessive production of the growth hormone in adults. Even that will make the individual to land up in the hypertension. Then hyperparathyroidism. So hyperparathyroidism is a scenario where there is excessive production of parathormone that will result in the hypercalcemia, and that will be the etiology for causing secondary hypertension. Then lastly, congenital adrenal hyperplasia. So these are all the endocrine causes for hypertension, right? So out of this, some of them will cause systolic hypertension and some of them will cause diastolic hypertension. Like for example, you take this Conn syndrome and as well as the hypothyroidism. Both of these conditions, they mainly cause the diastolic hypertension. Okay, so this is about the endocrine causes. Next you need to know what are the drugs which will predispose or which will cause the secondary hypertension. The drugs which will cause secondary hypertension include, number one, the alcohol abuse, then followed by that. So apart from the alcohol abuse, the other drugs which will cause the hypertension is oral contraceptive pills, then followed by that anabolic steroids, then corticosteroids, then followed by that NSAIDs, non-steroidal anti-inflammatory drugs, and then carbinoxolone sodium, next we have sympathomimetics, next followed by that cyclosporin, next followed by that we have sibutramine, next bromocriptine, right? So these are all the, and next one important drug which we use in chronic renal failure, that is erythropoietin. So these are all the drugs which will cause the secondary hypertension. Now we have discussed renal causes, endocrine causes, and as well as the drugs. And apart from that, the other causes for hypertension, it includes like congenital disorders like coarctation of aorta, next followed by that preeclampsia, that is in pregnancy, Next, lastly, some miscellaneous conditions, that is obstructive sleep apnea. So, these are the other causes of secondary hypertension: coarctation of aorta, preeclampsia and obstructive sleep apnea. Now, after having discussed about the various secondary causes for hypertension, now let me tell you what are the common causes of, isolated systolic hypertension. See, isolated systolic hypertension means only the systolic blood pressure is elevated, and that is seen in patients with the aortic regurgitation, then followed by that atherosclerosis, then patent ductus arteriosus will cause isolated systolic hypertension. Next, thyrotoxicosis will cause isolated systolic hypertension, then coarctation of aorta. So, these are the common causes of isolated systolic hypertension. Now, after having discussed about the causes for isolated systolic hypertension, let me discuss the clinical scenarios where there is wide pulse pressure, that is systemic hypertension with wide pulse pressure. So, wide pulse pressure in the sense, so how do you calculate the pulse pressure? Pulse pressure, it is systolic blood pressure minus diastolic blood pressure is what is your pulse pressure. And if you take the normal pulse pressure, it is around 30 to 60 millimeters of mercury. It is a normal pulse pressure, and anything above 60 millimeters of mercury will be a wide pulse pressure. So, where will you come across this clinical scenarios of the wide pulse pressure, and at the same time there should be a systolic hypertension? That can be seen in patients with decreased vascular compliance, that is in arteriosclerosis. Next, it is seen in clinical scenarios where there is increased cardiac output, that is in patients with aortic regurgitation, then followed by that thyrotoxicosis, next followed by that hyperkinetic heart syndrome, right, and in fever. Next, in individuals with arteriovenous fistula, that is AV fistula, then PTA, that is patent ductus arteriosus. So, these are all the conditions where you have systolic hypertension with wide pulse pressure. Okay, next. Now, followed by that, I'll just show you a clinical scenario, a very important clinical scenario where you have difference in the blood pressure between both the arms. So, that includes the following clinical scenario. A patient came with the early diastolic murmur in second intercostal space and had differential blood pressure recording in the upper limb, with one arm showing measurement of 150 by 110 millimeters of mercury and other showing 90 by 60 millimeters of mercury. All of the following can be a cause except aortic dissection, Takayasu arteritis, coarctation of aorta, supravalvular aortic stenosis. So, the answer in this clinical scenario is the supravalvular aortic stenosis. So, let me discuss in case of the aortic dissection. If the dissection, if it is progressing retrogradely into the aortic valve, the individual will develop aortic regurgitation, and as the individual develops aortic regurgitation, there will be development of the early diastolic murmur, right? There will be development of the early diastolic murmur. Then even in patients with the Takayasu arthritis and as well as the coarctation of aorta, you have difference in the blood pressure between both the arms. Right, difference in blood pressure between both the arms. Then what about your supravalvular aortic stenosis? Let me discuss about the supravalvular aortic stenosis. So, supravalvular aortic stenosis, it is characterized by an external hourglass deformity of the aorta. You see here, this is the hourglass deformity, right? This is the hourglass deformity of the aorta with a corresponding luminal narrowing at a level just distal to the coronary arterial ostia. See, this is the ostia, right? So, this is the coronary arterial ostia, just exactly distal to the coronary artery ostia, there is luminal narrowing, right? So, you can see that here. Right, there is luminal narrowing, and the discrepancies between the carotid pulsations and upper extremity pulses and blood pressures are characteristic clinical findings in supravalvular aortic stenosis. So, even in case of supravalvular aortic stenosis, you have difference in blood pressure between the two arms, right, between the right and left arm. And why there will be discrepancy and in which arm the pressures will be more? The discrepancies occur because the jet of blood flow from the supravalvular aortic stenosis area has a preferential trajectory into brachiocephalic artery. Okay, so from here the blood will jet with a greater pressure across the narrowed lumen, and the first important structure which will face that increased pressure which is developed across the narrowed lumen will be the right brachiocephalic trunk. Right, will be the right brachiocephalic trunk. So, the right brachiocephalic trunk is the one which will face the highest pressure rise across the lumen, right. So, the pressure will be very high, right, the pressure will be very high in the right brachiocephalic trunk, which is being transmitted into the radial artery or brachial artery of the right arm. So, the pressure in the right arm will be very high then compared to that of the pressure in the left arm, and this phenomenon is called as the Coanda effect, right. This phenomenon is called as the Coanda effect. Now, let me explain you once again what is Coanda effect. Okay, the discrepancies of the blood pressure between the two arms will be there in patients with the supravalvular aortic stenosis. Why? Because the jet of blood flow from supravalvular aortic stenosis, it has a preferential trajectory into the right brachiocephalic trunk. So, the pressure in the right arm will be very high then compared to that of the pressure in the left arm, right. That is called as the Coanda effect. And in patients with the supravalvular aortic stenosis, what will be the characteristic murmur? The characteristic murmur in case of supravalvular aortic stenosis will be a systolic murmur. Right, it will be a systolic murmur. So, what is that systolic murmur? Why there will be systolic murmur? Because the turbulence is created across that narrow lumen, right. The turbulence is created across that narrowed lumen during systole. That is the reason why it is considered to be a systolic murmur. And this particular systolic murmur, it is crescendo, decrescendo in shape. Right, it is crescendo, decrescendo in shape. And this particular systolic murmur, let me tell you, it is a low pitched murmur. Right, it is a low pitched murmur and best heard at the base of the heart. So where is this systolic murmur heard? It is best heard at the right, it is best heard at the base of the heart. So that is about the supravalvular aortic stenosis murmur, that is ejection systolic murmur, which is of crescendo decrescendo in shape, which is a low pitched murmur and it is best heard at the base of the heart. Okay. Now, whereas in the clinical scenario which has been given to us, what is described here? The individual has the presence of an early diastolic murmur, but in case of supravalvular aortic stenosis, what you have is the presence of the systolic murmur. Right, what you have is the presence of the systolic murmur. And you need to know or you need to understand that there is difference in the blood pressure between the two arms. Right, there is difference in the blood pressure between the two arms even in supravalvular aortic stenosis. Right, so that is about the clinical scenario of the supravalvular aortic stenosis. And in case of the coarctation of aorta, why is that there is difference in the blood pressure between the two arms? Right, this particular coarctation, most commonly it is distal to the left subclavian artery. Right, it is distal to left subclavian artery. But for suppose if this coarctation, if it is proximal, right, if the coarctation is proximal to right subclavian artery, that is the point when the pressures in the right arm will be more than compared to that of the pressures in the left arm. So right arm pressure will be more than compared to that of the left arm pressure if the coarctation is present proximal to the left subclavian artery. Okay, so now let me tell you all the conditions where you have unequal blood pressure between the right and as well as the left arm. So the mnemonic is TCSAO. So TCS like Tata Consultancy Services, so they are inviting you, that is AO. So T stands for Takayasu arthritis. Right, Takayasu arthritis. Then C stands for coarctation of aorta. Then the word S will be supravalvular aortic stenosis. Right, supravalvular aortic stenosis. And A stands for aortic dissection. Then the word O is obstructive aortoarthritis. Okay, so these are all the conditions where you have unequal blood pressure between both the arms, that is between the right and as well as the left upper limb. Then you need to know that a very important point, systolic blood pressure in a normal individual, systolic blood pressure in the lower limb will be more compared to that of the systolic blood pressure of the upper limb. This is the normal phenomenon. And how much will be the difference? The difference can be up to, right, the difference can be up to 20 millimeters of mercury, right? Now, there are certain clinical scenarios where you have the systolic blood pressure in upper limb is more than compared to that of the systolic blood pressure in the lower limb, and that is seen in post-ductal coarctation of aorta, right? That is seen in post-ductal, right, that is seen in the post-ductal coarctation of aorta. So, in post-ductal coarctation of aorta, please remember the systolic blood pressure in the upper limb will be more than compared to that of the lower limb. I will explain you the mechanism also. So, if you see this image over here, this is the image where you have a post-ductal coarctation of aorta. Post-ductal coarctation of aorta in the sense where the coarctation is present distal to the left subclavian artery. So, when the coarctation is present distal to the left subclavian artery, let me tell you the pressure, right, let me tell you that pressure in the upper limb will be more, or the blood flow to the upper limb will be more. Whereas, if you see the blood flow to the lower limb, right, if you see the blood flow to the lower limb, it will be less, okay. So, that is the reason why the systolic blood pressure in upper limbs will be more than compared to that of the systolic blood pressure in the lower limbs in clinical scenarios of post-ductal coarctation of aorta. Next, now, if you see the another scenario, systolic blood pressure in lower limbs is more than compared to that of the systolic blood pressure in upper limbs by a magnitude of more than 20 millimeters of mercury, that will be there in patients with the aortic regurgitation. Right, that will be there in patients with the aortic regurgitation. So, please remember now, clinical scenario where systolic blood pressure in the upper limbs will be more than systolic blood pressure in the lower limb, that is in postductal coarctation of aorta. Then systolic blood pressure in the lower limb will be more than systolic blood pressure in the upper limb by a magnitude of more than 20 millimeters of mercury, that is seen in the valvular aortic regurgitation, right? Next, followed by, and what is this sign in aortic regurgitation called as? This particular sign in aortic regurgitation, it is called as the Hill's sign, right? This is called as the Hill's sign. Next, followed by that, you need to know what are the genetic causes for hypertension. These are rare conditions, but you need to know what are those monogenic form of the hypertension, right? That is genetic causes for hypertension. So, we have autosomal dominant and as well as the autosomal recessive. So, autosomal dominant conditions causing the hypertension include number 1, Liddle syndrome, right, that includes number 1, Liddle syndrome, then followed by that pseudo hypoaldosteronism type 2, and that we call it as Gordon's syndrome, right, that we call it as Gordon's syndrome. And Gordon's syndrome is what? Pseudo hypoaldosteronism type 2, then followed by that polycystic kidney disease, right, and lastly pheochromocytoma. So, these are the autosomal dominant causes for the development of the hypertension. Next, you need to know what are the autosomal recessive causes for the hypertension? That includes 17 alpha hydroxylase deficiency, will cause hypertension, then 11 beta hydroxylase deficiency, then followed by that 11 beta hydroxysteroid dehydrogenase deficiency. Right, 11 beta hydroxysteroid dehydrogenase deficiency. So these are all the etiologies which will cause the hypertension, that is autosomal dominant causes and as well as the autosomal recessive causes for the development of hypertension. Next, followed by that, you need to know which of the following leads to hypokalemic metabolic alkalosis with hypertension. So the options include the Bartter syndrome, Gitelman syndrome, renal tubular acidosis, Liddle syndrome. So hypokalemic metabolic alkalosis with hypertension, that you will come across in patients with the Liddle syndrome. So in patients with Liddle's, you have hypokalemic metabolic alkalosis with hypertension. Now let me discuss about the Liddle's, why there will be hypokalemic metabolic alkalosis. So if you see this hypertension with metabolic alkalosis, that is Liddle syndrome. Liddle syndrome is the clinical scenario which is characterized by gain of function of epithelial sodium channels. Right, gain of function of epithelial sodium channel. So this we call it as the ENaC channel, that is epithelial sodium channel. So if you take this ENaC, what is the function of this ENaC? Right, what is the function of this epithelial sodium channel? See, the function of this epithelial sodium channel is sodium and water retention. Right, sodium and water retention, then followed by that the potassium excretion, and next the H plus ion excretion. Okay, so that is the function of the ENaC, that is epithelial sodium channel. So once there is gain of function of the epithelial sodium channel, there will be sodium and water retention, and that sodium and water retention will cause the expansion of the plasma volume and the gain of salt. Right, the expansion of the plasma volume and gain of salt. So due to expansion of the plasma volume and gain of salt, that will lead to the development of hypertension. Right, that will lead to development of hypertension. And there is corresponding potassium excretion within the urine and corresponding H plus ion excretion within the urine, and these two will make the individual to get predisposed to hypokalemic alkalosis. Right, hypokalemic alkalosis. Now how do you treat this Liddle syndrome? See, basically the epithelial sodium channel activity is increasing. So in order to block that epithelial sodium channel activity, the drug what we give is the amiloride. Right, the drug what we give is amiloride. So amiloride, it is considered as the drug of choice. Right, why? it is the one which will cause the blockade of the epithelial sodium channels. So it is an inact blocker, right? So this is the clinical scenario where you have hypertension with metabolic alkalosis, right? Hypertension with metabolic alkalosis. Now we have one more clinical scenario, that is hypertension with metabolic acidosis. What is the condition where you have hypertension with metabolic acidosis? That you will come across in patients with pseudo-hypoaldosteronism. So what do you mean by the word pseudo-hypoaldosteronism? Aldosterone levels, if you see, the aldosterone levels, they are normal, right? There is adequate amount of the aldosterone or adequate levels of the aldosterone, but the action of the aldosterone is not there. So there is renal tubular unresponsiveness or resistance to the action of aldosterone. So if you see, where will this aldosterone act? The aldosterone will act on the distal convoluted tubule. Right, the aldosterone will act on the DCT, and on which cells in the DCT? That is on the principal cells. Right, on the principal cells in the distal convoluted tubule, the action of the aldosterone is being present, and by acting on the principal cells of the distal convoluted tubule, there will be sodium and water retention, potassium excretion, and then the H+ ion excretion. That is what will happen when there is aldosterone. Now, the aldosterone action is not there, right? There is renal tubular unresponsiveness or resistance to the action of the aldosterone. So thereby, okay, so due to, right, there is resistance of the aldosterone action. So thereby there is no sodium and water retention. Right, there is no sodium and water retention. So once there is no sodium and water retention, there will be volume depletion, and once there is volume depletion, that will trigger, right, that will stimulate, right, that will stimulate the renin angiotensin aldosterone system, right? And once there is stimulation of the renin angiotensin aldosterone system, that will trigger, right, that will trigger the hyperreninism, that will trigger the hyperreninism, and once there is hyperreninism, what will happen? There will be hyperaldosteronism. Right, there will be hyperaldosteronism. Now, once there is hyperaldosteronism, this hyperaldosteronism will overcome the resistance, right? This increased aldosterone, see, physiological levels of aldosterone, there is resistance. That is what is your pseudo-hypoaldosteronism. But when there is hyperaldosteronism, that will overcome the resistance at the level of the distal convoluted tubule, and that will cause increase in sodium and water retention, and thereby making the individual to develop the hypertension. Okay, so that is about why there will be hypertension in patients with the pseudo-hypoaldosteronism. And in patients with the pseudo-hypoaldosteronism, what is happening in the early stages? The aldosterone action is not there, so the H+ ion is not adequately excreted out, right? The H+ ion is not adequately excreted out, okay, and thereby the individual will develop acidosis. Now this pseudo-hypoaldosteronism, we have two types. It is further classified into two types. So number one, pseudo-hypoaldosteronism type 1, right, that is pseudo-hypoaldosteronism type 1, So this pseudohypoaldosteronism type 1, it is called as the classic form. Right, this is considered to be a classic form. Whereas if you take the pseudohypoaldosteronism type 2, pseudohypoaldosteronism type 2, this is called as Gordon syndrome. So pseudohypoaldosteronism type 2, it is considered as the Gordon syndrome. And this Gordon syndrome, let me tell you, it is autosomal dominant type of inheritance. So this is the condition where you have hypertension with metabolic acidosis. So let me repeat, it is renal tubular unresponsiveness or resistance to the action of aldosterone. And once there is resistance to the action of the aldosterone, there will be volume depletion, and that will trigger the hyperrenism and hyperaldosteronism, leading to the hypertension. This we have two types, that is pseudohypoaldosteronism type 1, which is a classic one, whereas type 2, that will be your Gordon syndrome. Now, after having discussed about the hypertension with metabolic acidosis and hypertension with metabolic alkalosis, let me tell you like what is the blood pressure, how much it should be in a normal individual, and when do we call the hypertension, right? So let me discuss according to the revised guidelines and as well as the guidelines which were there previously. Okay, so what should be the target blood pressure? So if you see this table of the target blood pressure, so the guidelines have been changed from year to year. So if you see, according to the recent guidelines, like what we follow is JNC 8, that is Joint National Committee 8. So according to JNC 8, the target blood pressure in elderly individual. So what do you mean by the word elderly individual? Age more than 60 years, the target blood pressure, it should be less than 150/90. And in adults, the target blood pressure is less than 140/90. Adults in the sense age less than 60 years. And in those individuals who have risk factors like coronary artery disease, diabetes mellitus, chronic kidney disease, in them the blood pressure should be less than 130/80. So this is the target blood pressure according to JNC 8. And the American Heart Association has given a slightly different guidelines in 2017. So according to the AHA guidelines, in elderly the blood pressure should be less than 130/80, and even in adults the blood pressure should be less than 130/80, and in those individuals who have the risk factors also the blood pressure should be less than 130/80. So whatever might be the age group, the blood pressure should be less than 130/80 according to the American Heart Association target blood pressure goal. Now followed by that, if you see this question, in essential hypertension, changes seen in the heart are cardiac cell hyperplasia, cardiac cell hypertrophy, increase in the mitochondrial number, increase in the size of the mitochondria. So in essential hypertension, changes seen in the heart are the cardiac cell, the hypertrophy, right? So what is cardiac cell hypertrophy? It is increase in the size of the tissue. Right, increase in the size of the tissue due to increase in the size of the individual cell, right, due to increase in the size of individual cell. That is what you will observe in hypertension. Then whereas if you take the hyperplasia, in hyperplasia there is increase in the size of the tissue as a result of increase in the number of component cells. See here, it is due to increase in the size of the individual cell. Right, whereas in cardiac cell hyperplasia, it is increase in the size of heart or size of the tissue due to increase in number of cells, right, due to increase in the number of the individual cells. That will be the hyperplasia. Now, after having discussed about the changes in the heart in patients with the essential hypertension, now let me discuss the management of the hypertension. So the question is, management of uncomplicated essential hypertension is: no need to treat, diet modifications and exercise, diet modification and exercise and drugs, drugs alone. So remember, in case of uncomplicated essential hypertension, along with the drugs, even the diet modification and as well as the exercise is also very important. So what will be the diet modification and what is that exercise regimen and the drugs? Let me discuss. So if you take the lifestyle modifications to manage the hypertension, first and foremost, the weight reduction. See, you need to maintain the normal body weight. So how much should be the BMI? The BMI in the individual should be in a range of 18.5 to 24.9. Right, 18.5 to 24.9. That should be the BMI in an individual. So when this particular BMI is being maintained, or obese individual where the BMI has been reduced to 18.5 to 24.9, what is the advantage? You know, the systolic blood pressure reduction will be there if the adequate BMI is being maintained. That is 5 to 20 millimeters of mercury per 10 kg weight loss, right? 5 to 20 millimeters of mercury per 10 kg weight loss will be the systolic blood pressure reduction, right? Will be the systolic blood pressure reduction when you maintain the BMI of 18.5 to 24.9. Now, coming to the DASH diet. So, when you adopt the DASH diet, what do you mean by the word DASH diet? That is the diet rich in fruits. Right, the diet which is rich in fruits, the diet which is rich in vegetables, and the diet which is a low fat dairy products. Right, low fat dairy products. So if the individual consume or if the individual adopt this particular DASH diet, then what will be the systolic blood pressure reduction? That will be around, right, that will be around 8 to 14 millimeters of mercury. That will be the blood pressure reduction if the individual adopts the DASH diet. Then coming to the dietary sodium reduction. See, if the individual acquires or if the individual takes less amount of salt, reduce dietary sodium intake, right? And how much should be that reduced dietary sodium intake? That is, the individual should take 2.4 grams of the sodium or 6 grams of the sodium chloride. So when the dietary sodium reduction, if it is up to 2.4 grams sodium or 6 grams sodium chloride, then the systolic blood pressure reduction, right, the systolic blood pressure reduction will be around 2 to 8 millimeters of mercury, right, will be around 2 to 8 millimeters of mercury. So that will be the systolic blood pressure reduction when the individual consumes 2.4 grams of sodium per day or 6 grams of the sodium chloride per day. Then followed by that, right, the next important thing is the physical activity. See, when the individual engages in regular aerobic physical activity, right, when the individual engages in regular right? When the individual engages in regular aerobic physical activity. What is that aerobic physical activity? Such as the brisk walking, right? Such as the brisk walking. And what should be the duration of that particular brisk walking? At least 30 minutes per day, right? This particular brisk walking should be at least should be at least 30 minutes per day. So when the individual does this particular physical activity, then the systolic blood pressure reduction will be around, right? The systolic blood pressure reduction will be around 4 to 9 millimeters of mercury, right? Next, coming to the moderation of the alcohol consumption. So when the individual does limited consumption of alcohol, limited consumption to no more than 2 drinks per day. So in males, up to 2 drinks per day, whereas in females, up to 1 drink per day, right? Whereas in females, up to 1 drink per day. So 1 drink in the sense the 30 ml of the alcohol. So if this is the alcohol consumption in the individual, this can also reduce the blood pressure by 2 to 4 millimeters of mercury. So please remember, lifestyle modifications are also very important to manage the hypertension, right? Number 1, weight reduction. Number 2, acquiring the DASH diet. Number 3, dietary sodium reduction. Number 4, the physical activity. Number 5, moderate alcohol consumption. Now, apart from this lifestyle modification, medical management is also very important. Now, what will be that medical management is, you need to know what are the first line drugs, second line drugs and alternative drugs. So, if you take the first line drugs in blacks of all age groups, either it should be a calcium channel blocker or a diuretic. Second line drug will be the ACE inhibitor or angiotensin receptor blocker or a beta blocker or a vasodilating agent. And in individuals, right, you take the white population. In individuals of age group less than 55 years, the first line drug will be calcium channel blocker or diuretic or ACE inhibitor or angiotensin receptor blocker. Whereas in white population, the second line agent will be vasodilating beta blocker, right? Vasodilating beta blocker. And you take all others, that is white population of age group more than 55 years. In them, the first line agent will be calcium channel blockers or the diuretics. And the alternative, or that is the second line agent, will be the ACE inhibitor or angiotensin receptor blocker or vasodilating agent or the beta blocker has to be given. Now, regarding the resistant hypertension, please remember the drug that you need to add is the aldosterone receptor blocker. Right, to the existing drugs, you need to add this aldosterone receptor blocker, which is nothing but your spironolactone or eplerenone to be added. But anyways, I will be discussing about the resistant hypertension in detail. So, you see this question now. Management of uncomplicated essential hypertension is no need to treat, diet modification and exercise, diet modification and exercise and drugs alone. So, what is that you have to give? Diet modification and exercise, and along with that the drugs also have to be given. Next, followed by that we have a clinical entity called as the hypertensive crisis. Now, what is this particular hypertensive crisis and what are the forms of this hypertensive crisis? See, hypertensive crisis is that where the systolic blood pressure is greater than the systolic blood pressure is greater than 220 millimeters of mercury and diastolic blood pressure, it should be greater than 125 millimeters of mercury. right? It should be greater than 125 millimeters of mercury. That is what is called as the hypertensive crisis. That is what is called hypertensive crisis. And we have two forms of this hypertensive crisis. That includes the hypertensive urgency, and then we have the hypertensive emergency. Right, hypertensive urgency and as well as the hypertensive emergency. See, the hypertensive urgencies, these are the situation in which the blood pressure must be reduced within a few hours, right? So I'll tell you, in hypertensive urgency, I'll discuss about both this hypertensive crisis now. Hypertensive urgencies are situations in which the blood pressure must be reduced within a few hours, right? Within a few hours. Now, in these individuals, let me tell you, there is no end organ damage, right? Hypertensive urgencies are those conditions where there is no end organ damage. Please remember, this is a very, very important point, right? And even in case of hypertensive urgencies, the blood pressure is more than 220 millimeters of mercury by 125 millimeters of mercury. That is there. But these individuals, let me tell you, they are having asymptomatic severe hypertension. Right, so they are the individuals with asymptomatic severe hypertension, and there is no end organ damage, in the sense there is no hypertensive encephalopathy, there is no hypertensive retinopathy, there is no hypertensive nephropathy, and there is no hypertensive heart failure. So target organ damage will not be there in these patients with the hypertensive urgency, whereas, and so that is the reason why the blood pressure can be reduced within few hours, whereas if you take in case of the hypertensive emergencies, they require substantial reduction of blood pressure within 1 hour, right, within 1 hour. Why? Mainly to avoid the risk of serious morbidity or death, right, to avoid the risk of serious morbidity or death. In hypertensive emergencies, the blood pressure reduction should be done within 1 hour, okay? And so please remember one important point. What is the difference between hypertensive emergency and as well as the hypertensive urgency? In case of hypertensive emergency, there is end organ damage. Right, there is end organ damage, right? So in this, there is a critical multiple end organ injury, right? There is critical multiple end organ injury. Now what all those end organ injury includes is, number one, hypertensive encephalopathy, right, hypertensive encephalopathy. So hypertensive encephalopathy is the clinical scenario where the individual will have headache, irritability, right, then followed by that they will be in a state of confusion and altered mental status. That is what is your hypertensive encephalopathy. Then followed by that we have a clinical entity called hypertensive nephropathy. So hypertensive nephropathy is the scenario where the individual has the development of hematuria. Next, these individuals will also have proteinuria and acute kidney injury. So, these will be the features of the hypertensive nephropathy, right? And apart from that, these individuals can also have intracranial hemorrhage as well due to rupture of the blood vessels due to high pressures. And the cardiovascular manifestations secondary to the hypertensive emergencies include the development of the aortic dissection, right? The development of aortic dissection, and there can be development of pulmonary edema, that is your hypertensive heart failure. Right, that is the hypertensive heart failure. Then followed by that, the another important cardiovascular manifestations include the development of unstable angina, right, development of unstable angina or the development of myocardial infarction. So these are the features of the hypertensive heart disease. There can be development of aortic dissection, pulmonary edema, or there can be unstable angina or myocardial infarction. And in pregnancy, right, they can have the preeclampsia or the eclampsia. So these are the end organ damages, right, multiple critical end organ damages that can be seen in patients with the hypertensive emergencies, right. Now, these patients with the hypertensive emergencies, what did I tell you? They have to be seen that the blood pressure should be reduced within 1 hour. The blood pressure have to be reduced within 1 hour. Otherwise, this will cause very severe mortality within the individual. So, to summarize this hypertensive crisis, hypertensive crisis, right? So, according to the revised guidelines, the systolic blood pressure should be more than 220 millimeters of mercury and diastolic blood pressure should be more than 130 millimeters of mercury. So, next you need to check whether there is target organ damage is present or not present. If suppose, if there is no target organ damage, there is just only markedly elevated blood pressure, you need to just intensify the oral treatment. But if there is target organ damage, then in such case, you need to admit the patient to ICU. You need to assess the end organ which is damaged and what will be or what are the associated manifestations. For suppose, you have made out there is the aortic dissection which has developed in the individual. In such scenario, you have to ensure that the blood pressure has to be reduced to less than 120 systolic blood pressure. For suppose if there is no development of the aortic dissection, reduce the blood pressure by maximum 25% over 1 hour and then 160 by 110 over the next 24 hours. So, if there is aortic dissection development as a part of the hypertensive emergency, in them the systolic blood pressure should be reduced to less than 120 millimeters of mercury, and if it is not aortic dissection but some other hypertensive emergency, then you need to reduce the blood pressure by maximum 25% over 1 hour. So that is about the management of the hypertensive crisis. So now let me discuss the drugs used for the hypertensive emergency and as well as the hypertensive urgency. So for hypertensive emergency, the drugs what we use is through the intravenous route. So we use the intravenous agents. And what are these intravenous agents that are given for the hypertensive emergencies is that includes number 1, diuretics, right? Then followed by that we have vasodilators. And what are these vasodilators which we give in case of the hypertensive emergencies is mainly nitroglycerin. Right, mainly the nitroglycerin. Followed by that, the other vasodilators, it include phenyldopam, nicardipine, and then hydralazine. Right, phenyldopam, nicardipine, and then hydralazine. So these are the vasodilators which are given through intravenous route for the treatment of the hypertensive emergency. Then followed by that, the adrenergic inhibitors. These are the other group of drugs for hypertensive emergencies. So the examples of these adrenergic inhibitors include number 1, esmolol, then followed by that metoprolol, next we have labetalol, then subsequently we have phentolamine. So these are the examples of the drugs for hypertensive emergencies. Now you need to know what are the drugs we give for the hypertensive urgency. For hypertensive urgency, the route of administration is the oral route of administration. The drugs which are being used is nicardipine, right? Then followed by that we have clonidine, next subsequently labetalol, right? And next we have hydralazine, and next we have what is nitroglycerin. So these are the oral agents which are given for the hypertensive urgencies. So intravenous agents for hypertensive emergencies and oral agents for the hypertensive urgencies. Now depending upon the type of hypertensive emergency, certain drugs are being recommended. And what are those? Like for example, you take in case of the ischemic stroke, right? If the hypertensive emergency is an ischemic stroke, the drug which is being recommended is the nicardipine. And the drug which should be avoided is nitroprusside. See, this nitroprusside is no more used nowadays. And why is that? That is because of the cyanide toxicity. This nitroprusside is not being used. And if the individual is developed myocardial ischemia and myocardial infarction, then the recommended drug for this hypertensive emergency will be a short-acting beta blocker, that will be esmolol, and the drug that should be avoided is the hydralazine. Next, in case of the aortic dissection, in aortic dissection the drug which is being recommended is esmolol or labetalol. Right, esmolol or labetalol, and the drug that has to be avoided is hydralazine. Right, it is the hydralazine. Right, for suppose the individual has developed acute pulmonary edema due to systolic dysfunction, then in such scenario the drug what you need to give is the nitroglycerin, and along with nitroglycerin you need to give diuretics. Right, along with nitroglycerin you need to give diuretics, and the drugs that have to be avoided, that includes the hydralazine. and along with that the beta blockers also should be avoided. Right, beta blockers also have to be avoided. That is when there is development of acute pulmonary edema due to systolic dysfunction. Whereas if there is development of acute pulmonary edema due to diastolic dysfunction, then in such case you need to give esmolol plus nitroglycerin. Right, esmolol plus nitroglycerin, and for pulmonary edema you need to give diuretics. Right, and what are the drugs that you have to give if there is development of acute kidney injury secondary to hypertensive emergency? That includes phenyldopam. Right, that includes phenyldopam. So that is the recommended drug if there is development of the acute kidney injury. Now, after having said this, the various drugs which are used in hypertensive emergencies or hypertensive urgencies, I'll just show you a slide of the dosages of these particular drugs. So in hypertensive urgencies, what are the drugs? Clonidine, captopril, and as well as the nifedipine. And these are the respective doses of the clonidine, captopril, and as well as the nifedipine. And with the clonidine, one of the very important adverse effect that you need to remember or you need to monitor is there can be a rebound. Once you stop the drug, there may be a rebound hypertension. So that you need to be very much aware when you are giving clonidine to the individual. And this clonidine can cause a minimal amount of sedation. Next, followed by that, you take the hypertensive emergencies. In hypertensive emergency, the drugs what we give is nicardipine, clevidipine, labetalol, and then the esmolol. These are the drugs that you need to give in case of the hypertensive emergencies. And these are the respective dosages of the drug and the onset of action. If you see the onset of action, the quick onset of action is seen with the esmolol. Right? The esmolol, it has a quick onset of action. That is, the onset of action is within 1 to 2 minutes with esmolol. Right? Whereas the other drugs, if you see nicardipine, it is 1 to 5 minutes, then 2 to 4 minutes is your clevidipine, and labetalol within 5 to 10 minutes. Right? Now we have few more drugs. These are the other group of drugs which we give in hypertensive emergencies. That includes phenyldopam, enalaprilate, furosemide, hydralazine, and then the nitroglycerin. And even if you take nitroglycerin, this is the drug which we commonly use for the hypertensive emergencies, and the onset of action is within 2 to 5 minutes. Right? The onset of action is within 2 to 5 minutes. Then we have nitroprusside. This nitroprusside, it is no longer used as a first line agent because it is associated with the cyanide toxicity. It is associated with cyanide toxicity. So now these are some of the important points related to your hypertensive crisis, which is nothing but the hypertensive emergency and as well as the hypertensive urgency. And if you see a next question, hypertension patient has presented with the blood pressure of 220 by 130 millimeters of mercury. In the emergency, he is in hypertensive emergency with headache but no central nervous system deficit. What is the goal blood pressure for this patient? 200 by 150 millimeters of mercury, 180 by 110 millimeters of mercury, 160 by 90 millimeters of mercury, 140 by 90 millimeters of mercury. So please remember, this individual has no CNS deficit. Right? In this question, since no neurological deficit is being mentioned, it implies patient did not have any CNS event. And blood pressure should be gradually reduced to, right, blood pressure should gradually be reduced to 160 by 90 millimeters of mercury. Right? For suppose, if the individual had hypertensive encephalopathy, right, hypertensive encephalopathy in the sense where the individual has presented in a state of vomiting, altered sensorium or unconsciousness. In that patient, you have to reduce the mean arterial pressure by 25% over 8 hours using sodium nitroprusside. This sodium nitroprusside is no more used nowadays, right? What we can use is we can use the nicardipine, right? We can use nicardipine for reducing this blood pressure. And in a clinical scenario of the acute ischemic stroke, right? In a clinical scenario of the acute ischemic stroke. In a clinical scenario of acute ischemic stroke, remember, you need to thrombolize the patient after reducing the systolic blood pressure to less than 185 and diastolic blood pressure to less than 110 millimeters of mercury. And how can you reduce the blood pressure to less than 185 or less than 110? That is, by using labetalol or nicardipine, you have to reduce the blood pressure to less than 185 and then 110 millimeters of mercury. Then, followed by that, if the individual has developed intracranial hemorrhage with raised intracranial pressure, you have to ensure that the blood pressure has to be reduced to less than 180 millimeters of mercury, and mean arterial pressure you have to keep less than 130 millimeters of mercury. And if there is no features of raised intracranial hypertension, systolic blood pressure should be reduced to less than 160 by diastolic blood pressure of less than 90, and you need to keep a map of less than 110 millimeters of mercury. And whatever the clinical scenario which has been given here, it tells you there is no features of raised intracranial hypertension. There is no neurological deficit. So, in that patient, you have to reduce the systolic blood pressure to less than 160 by 90 millimeters of mercury. Now, in this hypertension, you have to remember one clinical entity called resistant hypertension. Resistant hypertension is that when goal is not achieved with 4 drugs plus diuretics, 2 drugs plus diuretics, 3 drugs plus diuretics, 5 drugs plus diuretics. Okay. So now let me discuss the 2 important terminologies, that is, we will discuss and then come back to that question, okay. What is resistant hypertension and what is refractory hypertension? Resistant hypertension is defined as the blood pressure remaining above the goal despite concurrent use of 3 antihypertensive medications, right. So you are using three antihypertensive medications. So, in spite of using 3 antihypertensive medications, the blood pressure is still above the goal. That is called as resistant hypertension. Now, among these 3 antihypertensive drugs, right, among these 3 antihypertensive drugs, let me tell you, one should be definitely a diuretic. So, these 3 should be of 3 different classes. Right, these 3 should be of 3 different classes, and ideally one particular drug in that should be a diuretic. That is called resistant hypertension. Then coming to the refractory hypertension. See, what is refractory hypertension? Refractory hypertension is almost seen around in 3 to 4% of patients. So, this refractory hypertension, it comes from individual from resistant hypertension. So, how do you define that? Refractory hypertension is the scenario where the individual has uncontrolled blood pressure, right? Is the scenario where the individual has uncontrolled blood pressure on more than or equal to 5 antihypertensives, right? So, the individual is on almost 5 antihypertensives, but still the blood pressure is above the normal limit, right. Still the blood pressure is above the normal limit. That is what is called as refractory hypertension. Resistant hypertension, the blood pressure is above the goal in spite of use of 3 antihypertensive medication. Refractory hypertension, the blood pressure is above the normal limit in spite of using 5 antihypertensive medications. Okay, next. Now, you see a question, this question now. Resistant hypertension is when the goal is not achieved with 2 drugs plus diuretics, right? Next. Now the next important question is, a hypertensive diabetic is having proteinuria. What is the antihypertensive of choice? Please remember, in individuals with proteinuria, the drug of choice will be ACE inhibitors. So ACE inhibitors, that is enalapril, is an ACE inhibitor. What it does is, ACE inhibitors will reduce the intraglomerular pressure. Right, will reduce the intraglomerular pressure, and thereby it will reduce the proteinuria. Right, thereby it reduces the proteinuria. So that is what is the treatment for proteinuria in patients with the hypertension. Now followed by that, most common cause of resistant hypertension is non-compliance of patient, obstructive sleep apnea, pheochromocytoma, renovascular disease. Most common cause of resistant hypertension is non-compliance of the patient. That will be the most common cause of the resistant hypertension. Now, if you see the list of causes for the resistant hypertension, one among that is the non-compliance of the patient. That means the individual is not taking the antihypertensives adequately. Right. Next, what are the other causes? Drugs. Okay, you see here, these are all the causes of the resistant hypertension. That is, number one, improper blood pressure measurement, then volume overload and pseudo tolerance. That is, the individual is consuming excess amount of sodium, or there is volume retention from kidney disease, or inadequate diuretic use. So all these, right, all these will cause the volume overload. Then followed by that, drug induced or other causes. One is your non-adherence, right, the patient not taking the drugs properly, antihypertensives. The other causes include like the administration of the drugs like NSAIDs, cocaine, amphetamines or other illicit drugs, sympathomimetics, oral contraceptives, adrenal steroids, cyclosporin and tacrolimus, it is erythropoietin, then we have licorice, and then supplemental substances like ephedra, and obesity, excessive alcohol intake. So these are all the drugs which can make the individual to land up in resistant hypertension. Now I'll just show you one important clinical scenario. A 50-year-old construction worker continues to have elevated blood pressure of 160 by 100 millimeters of mercury after a third agent is added to his antihypertensive regimen. Physical examination is normal, electrolytes are normal, and he is not taking any over-the-counter medication. What is the next helpful step in the diagnosis of this patient? You need to check the pill count, you need to perform the renal Doppler, MRI of the aorta, and then the adrenal CT. So he is a 50-year-old construction worker, right, and he is on 3 antihypertensives. See, taking into the economic status of the individual, he will not be able to get these 3 antihypertensives every day. So apart from that, the electrolytes are normal, physical examination is normal, and he is not taking any over-the-counter medication. Performing the renal Doppler will be of no use. Renal Doppler you will perform when there is renal artery stenosis, and in patients with renal artery stenosis there will be presence of abdominal bruit, which is not there in this individual. MRI of the aorta, that is mainly to diagnose either Takayasu arteritis or the development of aortic dissection. Both of those features are not there in the examination of the individual. Then adrenal CT. Adrenal CT we have to do to look for Cushing syndrome, Conn syndrome or pheochromocytoma. But this patient is having normal electrolytes, so that will rule out any abnormality within the adrenal gland. So you need to check the pill count in this individual. Why? Because the individual being a construction worker, he may not be able to afford the 3 antihypertensives every day. Next question is, Osler's maneuver is used for the diagnosis of pseudohypertension, infective endocarditis, auscultation of murmur of mild aortic regurgitation, cutis laxa. Osler's maneuver is used for the diagnosis of the pseudohypertension. Now, what is this Osler's maneuver? Why is that we need to do this? See, blood pressure may be falsely elevated in geriatric patients, right? Blood pressure it may be falsely elevated in falsely elevated in geriatric patients due to severe sclerotic arteries. Right, and this, right, because of this falsely elevated blood pressure due to severe arterial sclerosis, due to severe sclerotic arteries, this will lead to overdiagnosis of the hypertension. Right, this will lead to overdiagnosis of the hypertension. Hence, it is called pseudo hypertension. Right, it is called pseudo hypertension. And the clinical sign used to diagnose this pseudo hypertension is called as the Osler's maneuver. And how is that you will do the Osler's maneuver? Osler's maneuver, it is characterized by palpable radial artery impulse in spite of occlusion of the brachial artery by the blood pressure cuff. Right, Osler's maneuver is characterized by palpable radial artery impulse in spite of occlusion of the brachial artery by the blood pressure cuff. That is called the Osler's maneuver. That means you will be able to feel that radial artery pulsations in spite of occluding the brachial artery by the sphygmomanometer. That is called Osler's maneuver, which is used to diagnose the pseudo hypertension. Next, a female has a systolic blood pressure of 130 and diastolic of 100 on 2 consecutive occasions. Best treatment is taking rest, sedative, antihypertensive, error in the blood pressure machine. So, the individual is having diastolic hypertension almost 2 consecutive occasions. These patients, you need to add the antihypertensive drugs. Right, you need to add antihypertensive drugs. So, what are the causes of isolated diastolic hypertension? Causes of isolated diastolic hypertension include number 1, essential hypertension. Number 2, hypothyroidism. And number 3, Conn syndrome. Right, so these are the causes of the isolated diastolic hypertension. Right, essential hypertension, hypothyroidism, and then the Conn syndrome. Now, you see and these patients with diastolic hypertension, definitely they have to be given antihypertensive drugs. Next, a lady on antihypertensive medication comes with hemiparesis and speech difficulty of 2.5 hours. Blood pressure is 180 by 100 millimeters of mercury. What is the best treatment for this patient? Aggressive reduction of blood pressure, modest lowering of blood pressure, thrombolysis with tissue plasminogen activator, aspirin and clopidogrel loading dose has to be given. See, this patient is presenting with hemiparesis and as well as the speech difficulty. In the sense, the individual has developed some sort of cerebrovascular accident and the blood pressure is 180 by 100 millimeters of mercury. So, in this case, how much is the mean arterial pressure? If you calculate the mean arterial pressure, if you calculate, it is something around 130. It is actually 127 millimeters of mercury, right? That is about the mean arterial pressure. So, in this patient, what is that you have to do, right? What are the guidelines? Let me show you. In this patient, you have to do modest lowering of the blood pressure. Let me explain the guidelines. So, in this case, if you calculate the mean arterial pressure, it is around 127 millimeters of mercury, and according to the American Heart Association recommendations for treating the elevated blood pressure, it is as follows. If the systolic blood pressure is over 200 or mean arterial pressure is over 150 millimeters of mercury, then aggressive reduction of blood pressure with continuous IV infusion has to be done. But our patient is having a systolic blood pressure of 180, mean arterial pressure of 127. So, aggressive reduction of the blood pressure is not required. Then you take the second scenario, that is, for treating the elevated blood pressure, these are the other guidelines. If the systolic blood pressure is over 180 millimeters of mercury or mean arterial pressure is over 130 millimeters of mercury and intracranial pressure is elevated, then consider monitoring the intracranial pressure and reducing the blood pressure using intermittent or continuous intravenous medication while maintaining a cerebral perfusion pressure of 60 millimeters of mercury or higher. Okay. So, if the mean arterial pressure is 130, systolic 180, then you need to monitor the intracranial pressure and reduce the blood pressure using intermittent or continuous intravenous medications. But our patient mean arterial pressure is 127 millimeters of mercury. Next, you see the other guidelines. If the systolic blood pressure is over 180 or mean arterial pressure is less than 130 millimeters of mercury, and if there is no evidence of elevated intracranial pressure, then consider modest reduction of the blood pressure. And how much should be the target MAP and target blood pressure? The target mean arterial pressure should be of 110 millimeters of mercury and target blood pressure should be around 160 by 90 millimeters of mercury, right? So, our patient comes under this third category, right? So, what you have to do is modest lowering of the blood pressure has to be done. Next question. A 48-year-old woman has been diagnosed with essential hypertension and was commenced on treatment 3 months ago. She presents to you with a dry cough which has not been getting better despite taking cough linctus and antibiotics. You assess the patient's medication history. Which of the following antihypertensive medications is responsible for the patient's symptoms? So, the individual had developed dry cough, not even getting subsided with the antitussive medications and antibiotics. The options are amlodipine, lisinopril, bendroflumethiazide, furosemide and then the atenolol. Let me tell you, the antihypertensive which will cause dry cough is the ACE inhibitor. These ACE inhibitors, what they do is they increase the bradykinin levels, right? They increase the bradykinin levels. So, as they increase the bradykinin levels, that will make them to land up in development of the dry cough and as well as development of angioedema. So, lisinopril is the one which is responsible for that particular cough. Next. A 57-year-old male is admitted complaining of headache and blurring of vision. His blood pressure is found to be 240 by 150 millimeters of mercury and he has bilateral papilledema and is fully oriented and as well as coherent. He has been known to be hypertensive for about 5 years and his blood pressure control has been good on 3 drugs. However, he has decided to stop all medications 2 months before this event. Which of the following would be you preferred parenteral medication at this point? So, the presentation is headache and as well as blurring of vision and the blood pressure is around 240 by 150. Bilateral papilledema is there and the individual is fully oriented and as well as coherent, right? And almost since 5 years he is having hypertension, but he decided to stop all the medications 2 months before this particular event of headache and blurring vision. So, now what is that you will give at this point? The individual is in a scenario of the hypertensive emergency. The options are glyceryl trinitrate, hydralazine, labetalol, metoprolol and then the phentolamine. So, the preferred drug here is the glyceryl trinitrate, right? So, it is agreed that in situations where there is relatively rapid blood pressure lowering is indicated, previously we were using sodium nitroprusside, but Presently, the drug that can be used is the nitrates. Nitroprusside is not being used in the recent days because of cyanide toxicity, and we want rapid reduction of the blood pressure in this individual. So, glyceryl trinitrate is the drug which can be used for causing rapid reduction in the blood pressure. Okay, the answer is A. Next, you see another important clinical scenario. Okay, blood pressure is difficult to measure in a patient with mitral stenosis, aortic stenosis, complete heart block, atrial fibrillation. So, in patients with atrial fibrillation, it is difficult to measure. Why it is difficult to measure? Because this individual has an irregular pulse. Right, this individual has an irregular pulse. So, it is difficult to measure the blood pressure in this individual. Next, pregnant lady with hypertension with diabetes mellitus requires which drug to control her blood pressure? ACE inhibitors, beta blockers, angiotensin receptor blockers and diuretics. So, pregnant lady with hypertension with diabetes mellitus requires the beta blockers to control her blood pressure. See, even though the individual is diabetic, in pregnancy, we don't give ACE inhibitors. ACE inhibitors, they are absolutely contraindicated in pregnancy. And same is your angiotensin receptor blockers also. And diuretics, they are usually avoided in pregnancy because they can reduce the fluid within the uterine cavity. Right? That is, amniotic fluid can be reduced by your diuretics. So, that is why they are usually avoided. Beta blockers, they are the preferred drugs. Next, rapid reduction of blood pressure is indicated in options: acute aortic dissection, hypertensive encephalopathy, intracerebral hemorrhage, all of the above. So, all these are the hypertensive emergency scenarios. So, you need to do a rapid reduction of blood pressure in all these scenarios, that is acute aortic dissection, hypertensive encephalopathy and as well as the intracerebral hemorrhage. Next, in accelerated hypertension, what is the metabolic defect? Normal non-ionic metabolic acidosis, ionic gap metabolic acidosis, hypomagnesemia and metabolic alkalosis. Let me tell you, the metabolic defect that you will see in accelerated hypertension is the metabolic alkalosis, right? So, these are some of the clinical questions and single liner questions related to the topic of hypertension and a detailed discussion of the topic of hypertension. Thank you very much.